Hello, Anil.
Doctor, I can start now. Thank you.
Recording started, no, Anil?
Yeah, doctor, it will be in the YouTube.
Oh. Good evening, all. So, myself, Dr. Harish Malapura Maheshwarappa, from Bangalore, working as intensive care physician in Narayan Hrudayalaya, so Bomsandra unit. So, that is the main Narayana hospital. So, just to brief about myself before we go on to an orientation session on critical care medicine, you can take me as an example to get yourself motivated. Okay, so basically, so I done my MBBS from Mysore Medical College, so 2001 batch, and after that I finished my MD in anesthesia from Government Medical College Nagpur, so in 2011. So in the 2011, so I was not aware what exactly is this critical care medicine and all. So during that time, so first time we got introduced with like compulsory bond to be served in Maharashtra government. So lots of confusion started whether to go with some sort of further training in some other super specialty or to go for bond and all. So with this confusion, so I came back to Karnataka. So joined IDCCM in Narayan Hrudayalaya, Bangalore. So in 2011, like June, July, kind of this one. So while like finishing this IDCCM at the verge, so I came to know that so first time in India, MCI recognized DM critical care medicine has been introduced. So in Tata Memorial Hospital. So during that time, that was the institute specific exam. Lots of confusion whether to appear or not because it is first time introduced with some sort of Viva after you clear MCQ exam and all. So no guarantee. And I was in the verge of finishing IDCCM, and which was having a coincidence of both exam dates for IDCCM exit and that of like DM critical care entrance. So during the IDCCM, I have given national board entrance for FNB critical care medicine. So then like I got a good rank, so I opted for FNB also in the same institute. So in that tenure, I finished my DNB, that is the final DNB anesthesia from Government Medical College, Trivandrum. So by that time, I was already MBBS, MD, DNB. So doing FNB, IDCCM. With this confusion, I thought will not go for this entrance of DM critical care medicine. But in the last moment, I decided anyhow, it is an MCQ based exam, that is entrance exam. We'll get the same kind of MCQs in the IDCCM also. So someone advised, so why can't you go and appear so that you are going to familiar with the like some MCQs in critical care medicine. So then I packed my bag and so gone to Mumbai to give the exam. So exam was a bit tough with lots of negative marking and all. I thought, so I'm not going to clear. After next 24 hours, those who got good marks on hierarchy wise, they used to select 10 candidates to appear for the Viva, that is after the entrance exam. Then I thought, okay, I'm not going to get, so I packed my bag and returned back to Bangalore. So after 24 hours in the website, there was no announcement of the result and all. So when I came back to Bangalore, I given my IDCCM exam here. So considering DM, I might not get. Next 24 hours, no update on the result and all. With a curiosity, I just called the student section of Tata Memorial Hospital. So then they told, okay, so you are selected in the first list only for your like MCQ means entrance exam. You have a like first position kind of this one. And they asked, okay, you have to come over here for an interview, which is going to be scheduled today only. So around 1 o'clock. So this information I got at around 10:30. So then I thought it's not possible. I contacted head of the department there. So then I informed, so it's not possible from Bangalore to Mumbai within 2-3 hours and all. So then they scheduled for around 5 to 6 members next day of the like interview, Viva and all for the final process of selection. So I attended next day. So totally cleared. So it was very like impressive discussion in terms of like all clinical based questions and general view on the critical care medicine. I got selected for DM. So IDCCM I cleared. So DM, during the DM, so in the second year of DM I cleared EDIC part 1. So final year finished EDIC part 2. So by the time MBBS, MD, DNB, IDCCM, DM critical care medicine with EDIC and all. So this package I came out from the Tata Memorial Hospital. See why I am telling. So many of you guys may be pursuing your IDCCM currently, or maybe entered like DNB critical care medicine, DM critical care medicine. You want to have that track during your tenure of the residency, what you want to do. So it's not only finished there. So when I came out with the DM and all, I was already having 6-7 publications. After that, the same thing continued. So each year I used to publish at least 4 to 5. So publication in different national and like international publications. So almost more than 6-7 years, I'm a faculty in many of the national, international conferences, regional conferences. I organized couple of regional, state and national conferences also. Just to brief about this, so I'm currently training DNB critical care medicine, IDCCM candidates, IFCCM candidates. So actively involved in both administration, clinical and like academic overall critical care practice currently I'm doing. So basically to move forward, so when it comes to critical care medicine, so one idea what we were having, so many of the public, they were not aware. So is it a different branch kind of this one? So this has been established in the last 2 to 2.5 decades. Critical care medicine now is a well-established super specialty branch. It is not a specialty, it is a super specialty branch. So it is after MD, it is after DNB specialty. So it's well recognized, still growing. In this pandemic, it got very good weightage in terms of identification of the work done by the intensivist. No doubt it's going to be continued in future also. So many of the specialties, like they started opting for critical care medicine. So definitely the first question, if you take what is the scope of critical care medicine, so scope is there, no doubt on that. So now when they start having this beginning of pandemic, each of the small hospital in a binary center, in a district level also, they started having like intensive care unit with a labeled trained intensivist and all. So definitely there is a scope. And with the advent of lots of therapeutic interventions, so lots of like upgradation in the clinical knowledge, lots of evidence has been developed. So to have a good outcome when a patient stayed in ICU also. So basically, if you go back to decade back, ICU means it's the end of the story, patient is going to die. So next that concept changed to, if a patient gone on mechanical ventilator, so he's going to die. So ventilation means end of the story. So now even patients who are on ventilator, so stayed for 2 months, 3 months, so they are coming out and they are walking home, so without any sequelae and all, even though they took time. So lots of complications and all, many patients are surviving. That is happened because of the structured training. So structured improvement in our like approach, protocolized approach to manage critically ill patients, lots of therapeutic, okay, so diagnostic modalities available to improve the overall outcome. So it is evolving branch. Each day we are having a like some other controversies addressed, some more newer controversies, criticism came into picture in the field of critical care medicine. Definitely there is a scope. So in India, in abroad also, no doubt on that. Okay. So is it stressful to practice critical care medicine? See, this is like how we take. So basically when you are a resident, so maybe you might get stressed out because of the extended duty hours. Okay. So night duties, because so it is not like any other specialty without any night duty and also critical care medicine residency, 100% you need to do the night schedule. So just I'll give an example. Our schedule was like continuous 6 days night, 6 days like that. Okay. So you continue, means start from Monday to Saturday. So like Sunday, we used to have the changeover from night to day shift or day to night shift, like that. So basically when you start your like night, means you have to go at around 5:30, take the handover, settle the patient, inform the rounds to the consultants and all. So next day morning 8:30, you give the handover. So go take a breakfast, sleep. Again, if any academic activity, come at around 3 o'clock for the academic activity, mortality meeting, so journal club. Okay. So next, if you have time, go back to room, again come back. Otherwise, you continue taking the handover and start duty and all. So this was the schedule for our DM residency. Okay. So definitely in the residency, you feel a bit of stressful depending upon where you are working, what is your structure of working pattern, working hours and all. But when you started practicing critical care medicine with a very good knowledge and all, don't feel like stressed out, because you give a very good outcome to the patient. So you see the course of the illness in a dynamic way. So fluctuations you are going to observe at the end of the day when a patient survived. So you enjoy that. So when you start practicing critical care medicine, you might not feel stressful. So other stuffs you have to manage, like the family, counseling, some administrative issues, all those things you need to manage. Otherwise, academics, okay, so work may not be so much stressful when you start practicing critical care medicine, because if you're a junior consultant, associate consultant, you are going to have a fixed hours, 8 hours duty, give the handover, go home. So only a bit of headache is going to be there for a like head of the department, so or who is the lead of that critical care unit. So he has to sort out lots of things in relation to NABH, JC accreditation, okay, infection control policies, CPR committee, antibiotic stewardship committee and all. Because in all these things, so intensivist is the one who is going to have a role there. Okay, so whether it is a infection control committee, so they conduct monthly one meeting and all, so you need to contribute to that. CPR committee, so antibiotic stewardship committee, so all these NABH observation, data maintenance, okay, compliance with documentation, training the nursing staff, respiratory therapy, physiotherapy. So all these things are a bit extra burden to an like head of the department. Otherwise, it is not so stressful. Okay. So next question for the trainees, those who are currently in some sort of maybe graduate, post graduation and all, when to start preparing for critical care medicine exam. So it means an entrance exam. Okay. So to opt critical care medicine as one of the super specialty, see, best time is second year of MD or DNB, whether it is an anesthesia, emergency medicine, or pulmonology, that is a chest medicine or internal medicine. So best time is during the second year. You might get some adequate time to get oriented. So what exactly the critical care medicine? See, in my residency during the MD, we were not having any idea at all. So we are managing one post anesthesia recovery unit, so where we were having some ventilator. And as I told, so the concept so we were having is, when a patient gone on mechanical ventilator, so is going to die. So that was our concept. Okay, so basically like if you get a time, best time to get oriented on critical care medicine is going to be during the second year of residency. From that time you can have some track, okay, what's happening, what exactly is the critical care medicine, so what variety of cases you are going to see, so what is the prognosis, what is the outcome. So some orientation you can get during the second year of your residency. That is the optimal time. Final year you are going to be with your thesis work, and you have to like read for your exit exam of an MD or DNB according to the specialty, so what you are practicing. But the best time is during the second year to get all those steps into our mind. So what to read in critical care medicine? So as I already told, so this is one branch so which is continuously evolving. Okay, so you are going to get the same concept a bit changed if you are going to get an evidence in the next 2-3 months. For example, so we know that this thiamine, hydrocortisone, vitamin C, we use it like anything. So after 6 months to an year, so then we understood, okay, may not be helpful at all, kind of this one. Okay, currently we are using stress dose of steroid kind of like in all the patients with a sepsis background and all. So again we had a trial called adrenal trial, so which doesn't show any major outcome benefit and all. So we used colloids, we put a full stop to that. Okay, so like hydroxyethyl starch and all. We used liberal strategy for blood transfusion, so then we put a full stop. So restrictive strategy is okay, kind of this one. Okay, we use too much of fluid. We came to know that cumulative fluid balance is going to have an harmful impact in terms of morbidity, mortality. So why I am telling all these examples? So what to read in critical care medicine? You need to read the review articles. Okay, so basically any good review article which published in major critical care journals, they take through the like pathophysiology, so a bit on the etiology, a bit on the dynamicity of the like causative factors and their impact on the pathophysiology and all. They are going to criticize what happened till that time when it get published. Okay, so better way to understand critical care medicine is to read a good review articles. Okay, because textbooks, so you will get some basic concepts and all, but it is not criticized in terms of evidence and all. So that's why, so always suggestion to read critical care medicine is from the review articles. I'll just give an example how I prepared. See, during my Idccm, so I started collecting the review articles from some of the refresher course and all. So like liver, hepatic encephalopathy, hepatorenal syndrome. Okay, so upper GI bleed, like hepatopulmonary syndrome, one or two articles, and we made a folder for the liver. So ARDS, okay, how to ventilate ARDS, adjunctive therapies in ARDS, fluid management in ARDS, okay, recruitment strategy in ARDS. So evidence which tells about low tidal volume, PEEP and all those things in ARDS, one folder. Okay, so sepsis, one folder. So then COPD, asthma, toxicology, snake bite. So each like topic I started making one folder. Take a printout of the review article from very good journal and keep it collected, kind of this one. So when I finished my Idccm, that continued till my first year, second year of DM critical care medicine. In the middle of DM critical care medicine, so I made index to all those collected like stuff, whatever I had a printout of review article. So we given like name and that of the page number also indexed. So basically, then I made it the spiral binding, so that become almost around 23 to 24 books. Okay, so from that onwards, I totally stopped reading any textbook and all. So revised the same thing for all the exams. See, I appeared for almost all the exams. Idccm, okay, so it means National Board Entrance Exam, DM Exit Exam, DM Entrance Exam, EDIC Part 1, Part 2, kind of this one. So whatever the major exams which are going to be in critical care medicine, I appeared for all those exams and I cleared. So whatever I cleared, I used the same stuff. So each year I used to add the newer evidence to those review articles and all. So when I exited from the DM, when I left the Mumbai, so many people took that Xerox of all those 22, 23 books, spiral binding books, which are indexed and all. Okay, so currently I'm keep on adding to that collection, may not be in a printed way, but in a folder wise, kind of this one. Okay, so that's why my suggestion, so critical care medicine, you follow one basic book. So maybe OS critical care medicine or any of the ICU protocol book from the Indian Society of Critical Care Medicine, which you feel comfortable. But always recommendation is to take a printout of one or two good review articles. So that is what you are like supposed to read in critical care medicine. One or two review articles on each topic. That is very, very important. You mark it, okay, you make some notes of it, whatever. So that is the way you should read for critical care medicine. So next question is options available in critical care medicine in India and abroad. That I'll take in detail. So like next other questions which I am going to discuss in this orientation session is how to prepare for EDIC I, European Diploma in Intensive Care Medicine, Part 1 and Part 2. So how to prepare for European Diploma in Anesthesia and Intensive Care, Part 1, Part 2. So how to prepare for Neet Super Speciality exam. So currently, which is being scheduled in January month, January 10th. So lots of confusion happened in the last 2 months. So they came with the idea of changing the pattern of Neet Super Specialty. So everyone got confused, everyone got frustrated. Okay, so what is going to happen? So all the questions will come from general medicine. So no one is going to address which are the candidates from the anesthesia background, pulmonology background, emergency medicine background, when the questions are going to be from the internal medicine, general medicine. That confusion started, and people started getting agitation, okay, irritability, frustration, and all, what to do kind of this one that I'm going to address. How to prepare for IDCCM, FNB, DNB, DM exit exam. So that also I'll cover. So options in India, when it comes to critical care medicine options in India, we have certain options after MBBS, okay, after diploma in anesthesia or diploma in TB and chest medicine, that is DTCD, and we have options after MD or DNB, okay. So we'll discuss one by one. When it comes to after MBBS, see, I don't suggest like you have to concentrate like post MBBS course. I always suggest people to first finish off your basic post-graduation, whether it is an internal medicine, pulmonology, anesthesia, emergency medicine, DNB or MD. So it doesn't matter, but opt for a master degree, okay. So post-graduation degree after MBBS. But suppose with some sort of like difficulties to get through any of this NEET specialty entrance and not able to go for any of the specialty DNB or MD, you want to pursue post MBBS critical care medicine options in India. We have something called like post MBBS post certificate of training in critical care medicine, CTCCM. So it has been offered from Indian Society of Critical Care Medicine. So basic eligibility is going to be MBBS or an equivalent allopathic medical degree with a valid MCA registration. Very, very important. So even we have the MBBS degree offered from other than India, maybe China, Russia, okay, so Philippines and all those things. But if you have a MCA recognition, you have cleared that MCI FMG exit exam and all, if it is been MCA recognized, so then you can opt for this CTCCM program, that is post MBBS. It is a 2-year duration. So usually before February 15th every year for January batch, okay. So then before August 15th every year for July batch is going to start. Means upper limit is February 15th for the January batch, upper limit is August 15th for the July batch. So twice it's going to be conducted. Many of the corporate centers across India having this post MBBS like critical care course, like post MBBS candidates with a proper MCA recognition can opt for it. So this is going to have an exit exam. Basically, candidates are going to be assessed in the exit exam conducted after the completion of 2 years of training, and will comprise of the theory exam, which include around 100 MCQs, practical exam to be given by only those candidates who are going to pass the theory exam. So 2-year program post MBBS with a proper valid recognition from the MCI. So practical exam, so like other critical care exit exam, it is a well-structured program. So 2 cases, including the history taking examination, documentation. So 3 tables, including basics of ABG, ECG, drugs, radiology, ACLS, okay, and airway and basic ventilation are going to be asked in the Viva practical exam. So successful candidates will be given certificate of completion of critical care certificate course and can proceed to do IDCCM. So if they cleared post MBBS 2-year CTCCM program, okay, so they can appear for IDCCM, which is going to be 2-year for them. Post MD, post like DNB, IDCCM is going to be 1 year, Indian Diploma in Critical Care Medicine. That is also from the Indian Society of Critical Care Medicine. You can get the details in this website. But if it is a post MBBS CTCCM, they want to pursue IDCCM, there is a possibility, but it is going to be 2-year program. So that we need to remember. So one more post MBBS like program in critical care medicine, that is called Fellowship Examination of the College of Critical Care Medicine, FCCCM. Okay, you will get details in icueducation.com website. So again, it is a post MBBS course. It has been also called as Indo-Australian Fellowship in Critical Care Medicine and all. So Dr. P.N. Jain started this program. So it is a 2-year fellowship program in critical care medicine. Again, allopathic doctors, means not Ayurvedic doctors or homeopathic doctors and all, who are having a valid MCI registration or a state registration from India or abroad, can opt for this 2-year post MBBS like critical care fellowship program. So MBBS and at least 2 years of hospital experience after the internship, okay, of which at least 1 year the candidate should work in critical care medicine before they opt for this FCCM program. So it is also open for diploma in anesthesia or chest medicine, that is DA or DTCD, and at least 1 year of experience in critical care unit is required. So DNB medicine, chest physicians, okay, means chest medicine, anesthesia can opt for it. MD medicine, so chest medicine, anesthesia in India are equivalent from other countries with a valid MCA recognition, registration can also opt. So obviously, so when a person done with the MD or DNB, so you'll opt for an IDCCM, okay, so then going for this, but there is an option for like this post MBBS course for a MD and DNB, DA, DTCD candidates also. So there is an exemption from part 1 examination. This exit exam is also having part 1, part 2. Part 1 is going to be theoretical, part 2 is viva and practical, case presentation, table viva, all those things are going to be there like an other critical care exit exam. But you have to remember, so there are some amendments since April 2017. So those who have a MD, DNB, either from a general medicine, chest medicine, anesthesia, or diploma in anesthesia, DTCD, so with 1 year ICU experience, they are exempted from giving part 1 examination. So they can directly appear for the part 2 examination. That is an exemption. Otherwise, so they have to go through the very well structured like exit exam, that is both theory and that of the like practical. See, I attended as one of the examiner for this FCCM. So it is a very well structured exit exam, very well conducted, and they issue the degree, they do all these some sort of felicitation program and all those things, like how it's going to happen in an university kind of this one. So that is about the one more post MBBS option in India, that is also called as Indo-Australian Fellowship in Critical Care Medicine. So many of the corporate hospitals, particularly in Hyderabad, okay, in Gujarat, Ahmedabad and all, so in other north like states of India, they conduct this 2-year program in critical care medicine for post MBBS. So with proper structured program and all those things. So next is, suppose like you are not post MBBS, but you finished your DNB or MD either in emergency medicine, anesthesia, internal medicine, so or pulmonology or chest medicine. You have a degree, okay, post graduation degree. So then the option is you can appear for the Neet super specialty critical care medicine entrance exam, okay, so currently which is going to be scheduled on January 10th 2022. After lots of confusion, lots of changes in the dates have been made, so results are expected to come on 26th February 2022. So total DNB critical care medicine are 116 to 120. So previously it was labeled as so FNB critical care medicine. Now there is no FNB, it has been converted into proper 3-year DNB critical care medicine. So with a proper thesis, guide allocation, okay, so you have to submit the thesis, it should get approved from the national board. So then only you are able to appear for the exam. So now in the coming June, first batch of DNB critical care medicine, they are giving the exam, okay. So these are the eligibility for appearing to the entrance exam of Neet super specialty critical care medicine. So we have the same Neet, okay, exam from the national board, so which you can opt for the DM critical care medicine also, but the DM seats are limited. So there are certain institute, they have their own entrance like AIMS, PGI Chandigarh and JIPMER, but other remaining institute including Tata Memorial Hospital where I done my DM also currently comes under Neet super specialty critical care medicine, means like entrance exam, which is going to have a 2 question paper in the current like in the previous exam pattern and all. So but we don't know, with confusing like recommendation from the national board, what is going to happen to the next batch onwards, but I'll discuss on that also. Part A, the question paper in the part A, which is going to consist of MCQs from the eligible feeder broad specialty course, means you are from a anesthesia background, general medicine background, pulmonology, emergency medicine, so you are going to get that as a feeder broad specialty. So then you can expect the questions, so near about 40%, 40 questions are going to come from that, so feeder branch. So that is about the part A question paper. Okay, so part B is going to have the 60 questions which are related to the super specialty, which include the clinical practice, so basic science. The super specialty is going to be the critical care medicine. So this is the current division: 60%, 40%, 40% from anesthesia, general medicine, or whatever the broad specialty, and 60%, 60 questions are going to be to the like super specialty to which you are appearing. So the confusion happened. So currently they quoted, so the questions are going to from entirely from the internal medicine and all. So all anesthesia background candidates, so pulmonology, emergency medicine, they got confusion. Okay, so how they are able to answer the questions which are going to be from the like internal medicine or general medicine background. So they thought we'll keep a same paper for cardiology, endocrinology, critical care medicine, everything and all. But if you think, so it's not going to happen maybe in the next coming entrance also, because people will go to court. So that's already happened. So they will again put a stay order for this kind of decision and all. So worst scenario, if it get implemented also, don't worry, I'll explain why. Okay, so paper A, so around 1 hour 15 minutes, so total 160 marks it's going to have. So negative marking, yes, 1 mark will be deducted for every incorrect answer. So total questions are 40. So 40 into 4 marks per question. Okay, so 160 total marks. So paper B, 1 hour 15 minutes, total marks are around 240. Negative marking, again, yes, 1 mark will be deducted if for one wrong answer answered. So total questions 60. So which are from the super specialty, basic science, and the clinical practice, that is critical care medicine. So 60 into 4, that is 240 total marks. Okay, so factors affecting NEET super specialty cutoff. So some people ask, sir, what is going to be the cutoff? If you see the previous cutoff, it's going to be ranged in between 170 to 190. So that is the cutoff for NEET super specialty critical care medicine. They published in many of the websites and all, which depends upon percentage cutoff of the entrance exam, the difficulty level of the examination, total number of seats available, number of candidates who appeared for the examination, number of candidates who qualify for the NEET super specialty entrance examination. Okay, so that define the cutoff value for the NEET super specialty critical care medicine. But usually it happened in between 170 to 190 in the previous two, like DNB critical care medicine. So these are the colleges where we can find the availability of the DM critical care medicine. I have not included like AIMS and associated AIMS Institute, including Delhi and other centers and all. But these colleges will come under the NEET super specialty when you opt for like critical care medicine super specialty, which are like around 30 to 35. So this is the count, around 33 DM critical care medicine seats are there. But again, varied with the fee structure. Okay, some institute have some like post completion bond you need to serve. Some institute don't have the bond and all. So some institute, they are starting at the means first batch of DM critical care medicine, so that you need to see the pros and cons and all those things. Okay, so that is about DM in the like NEET super specialty, which has been a common entrance for DM and that of the DNB. We have separate exam for AIMS, PG, and JIPMER. Those institutes also offer DM critical care entrance exam. They have a stage 2, like some sort of performance evaluation. So first stage, it is an MCQ based. Second stage, it is going to be Viva based. Okay, you qualify MCQ with a 50th percentile or above, so then you are going to be eligible to appear for the Viva. So in the Viva, so most of the questions are going to be in and around like why you want to pursue critical care medicine. So what you have done, interesting things in the critical care medicine after your MD or DNB. Okay, so have you have any publications, presentations, okay, in the critical care medicine? Very, very important, because I appeared for the DM Viva, means entrance Viva, after I got a rank in like written MCQ exam and all. So these kind of questions, then like they will frame a case scenario. Okay, so they will ask some recent evidence, which is called as a landmark paper, therapy changing means paper kind of this one. But it is very important to have some CV strong with some publication, with some presentation and all. Very, very important. That's why you need to have that mentality from the post graduation itself, to publish, to present poster presentation, okay, case presentation, case report, whatever it may be, you should have. That helps in making your CV strong, which helps in appearing for the DM entrance Viva exam, okay? So for AIMS, PG and Chandigarh. So this is the $1 billion question, okay, $1 million question. So is it really have an impact because of new pattern of NEET, if it is going to happen from the next like NEET super specialty entrance? Answer is no. Okay, what is exactly the critical care medicine? Okay, so almost 60 to 70% is going to be internal medicine. If they ask questions related to endocrine, so thyrotoxicosis, okay, hypothyroidism, diabetic emergencies like diabetic ketoacidosis, hyperosmolar hyperglycemic status, hyponatremia, hypernatremia, it's a critical care medicine and it's an internal medicine. You need to read for both, okay, for both community acquired pneumonia, okay, sepsis, ARDS, toxicology, snake bite, okay, myocardial infarction, stroke. So bit you need to concentrate on the trauma, rheumatology, connective tissue disorder, hardcore HIV, tuberculosis, leprosy, these kind of topics. Otherwise, 60 to 70%, okay, burns, so fluid management, so it is an internal medicine, and that of anesthesia and critical care medicine. You can't put a clear cut margin, okay? So, and no need to worry on this also. Oh, next year pattern is going to be changed. Oh, we'll start reading only hardcore medicine and all. So definitely at least 50% you are going to have a questions in and around the critical care medicine, which is the same as that of the general medicine also. Because being a internal medicine PG also, you need to read all these things, okay? Without that you are not able to clear your exam. Maybe ventilator associated pneumonia, okay, so bloodstream infection, tropical infection, dengue, malaria, leptospira, like current pandemic, that is COVID, that is medicine, that is critical care medicine also. COPD, asthma, that is medicine, critical care medicine. So maybe interstitial lung disease, okay, cystic fibrosis, okay, so other some sort of pulmonary fibrosis, primary pulmonary fibrosis, all these things. Pulmonary embolism, internal medicine, critical care medicine, okay, deep venous thrombosis. So pharmacology, antibiotics, anticoagulation, so steroids. So all these things are going to be medicine and critical care medicine. No need to worry on that, okay? So maybe I told some hardcore topics like pulmonary fibrosis, so connective tissue disorder, so rheumatology, hardcore HIV, tuberculosis, leprosy, these kind of topics you might require to read from general medicine textbook or general medicine MCQ books and all. So otherwise, so it is going to cover 60% if you prepare with the critical care medicine background. So no doubt on that. So don't worry about this. So this is the take home on this question, okay? Next, suppose you have MD or DNB degree or DTCD, DA, or you completed CTCCM from the Indian Society of Critical Care Medicine, and you don't want to appear for any of the NEET super specialty, okay, either a DNB or DM critical care medicine, then you have an option, that is Indian Diploma in Critical Care Medicine from Indian Society of Critical Care Medicine. Now it is like more than 2 decades old, that is Indian Society of Critical Care Medicine. This is again a well-structured program, okay. Duration of IDCCM is for 1 year. So post MD, MS, DNB candidates, okay, and 2 years after DA, DTCD or CTCCM are equivalent candidates. CTCCM is, that is post MBBS course and all. So duration of IDCCM is 1 year for FCPS medicine candidate, so which is effective from 2020 registration. So this FCPS is the degree. So there is a board called CPS board in Maharashtra, particularly in Mumbai and Pune and all. So they offer this FCPS degree in general medicine, internal medicine. So they can also take this IDCCM, that is for 1 year tenure, okay. So diploma in anesthesia, DTCD 2-year program, MD medicine, chest medicine, anesthesia, DNB medicine, chest medicine, anesthesia, MDR, DNB emergency medicine, CTCCM, that is a post MBBS course, MRCM. So if it is approved from Medical Council of India, so this is the emergency medicine master degree, FCPS medicine, this is for 1 year, okay. So all these candidates are eligible to appear for IDCCM. So exit exam is going to be having a written exam which is based on MCQs. What to read for IDCCM? Remember, so again you need to concentrate on the review articles, okay, with upgraded review, with very good evidence-based knowledge, revise it, okay, you have to consolidate. So if you want to follow one textbook, so basic Bible is Washington Manual of Critical Care Medicine. So revise it 1,000 times before you go for like MCQ exam of the IDCCM and all. So usually, which is held in March and in August, center may vary. So it consists of multiple choice questions. Okay. So again, when to appear for IDCCM entrance level. So it is going to be done in January session and June session. So usually first week of January, so they start enrolling the candidates for IDCCM. It is going to happen just based on the some sort of interview. There is no entrance exam for IDCCM. It depends upon the interviewer. Okay, so he's been a recognized teacher for IDCCM and it is institutional specific. So there is no specific entrance for entry into the IDCCM and all. So don't have any entrance. So exit exam theory is going to be MCQ. So usually it doesn't have any negative marking and all. Practical is a very well structured, very well conducted exam because I cleared the IDCCM. So the oral exam is conducted by a panel of 6 examiners over 1 day, which includes 2 typical ICU case scenarios. So each case scenario by 2 examiners, on which questions will be asked by the examiner. So it may be burns, okay, difficult airway, or severe acute pancreatitis, or it may be toxicology, trauma, okay, COPD, asthma. So 2 cases they are going to discuss, case scenarios, table viva on ACLS, okay. So and airway skills, that is very, very mandatory for passing. So table viva on the interpretation of ECG, biochemistry, biochemical lab report. It may be on refeeding syndrome, okay. So Tpn complications, so like including acalculous cholecystitis, hypertriglyceridemia, hyponatremia, hypernatremia. So all these biochemical abnormalities, including ammonia, hepatic encephalopathy, X-ray findings, CT, MRI, so are going to be asked in the table viva. So table viva on setting up of ventilator. So they might ask, so set up the ventilator strategy for ARDS. Okay, they will give a case scenario. They will ask, okay, how to set initial setup for the ventilator, how much tidal volume, how much PEEP, how much respiratory rate, okay, trigger. So all those kind of questions they are going to ask. Setting up of hemodynamic monitoring like central line, arterial line, including setting up of a pressure transducer, how much pressure, how you are going to do zeroing, de-airing, priming, okay, leveling, all those things are going to be asked. Cardiac output monitoring skills, invasive, non-invasive, calibrated, non-calibrated devices and all, bedside monitoring of other gadgets in critically ill patients, okay, which may be ICP monitoring, IABP, okay, so that is a mechanical supportive strategy, okay, so or maybe thromboelastographic curves and all those things. You have to prepare in a structured way for the practical exam of IDCCM. So table viva on commonly used drugs, including the antibiotics, okay, acute resuscitation drugs, along with that of adjunctive therapy, including IV fluids, are going to be asked in the viva. So there will be 2 heads in practical exam. Head 1, 2 clinical cases of 40 marks each, total of 80 marks. So head 2, like 6 workstation of 20 marks each, total of 120 marks. So pass mark is like 50% in each head. Passing in each of these heads individually is compulsory, okay. So cutoff is 40 marks for head 1 and 60 marks for head 2. That is the 50% of the head 1 and head 2. So aggregate should be above 50%. So then only you are able to cleared as passed in IDCCM. So it is a very well structured exam, no doubt. And you have to read thoroughly, you have to practice at the bedside. So then only you are able to clear this IDCCM exam and all. So then we have Ifccm, that is Indian Fellowship in Critical Care Medicine, Ifccm. So this is going to be 1 year duration. This is after mandatorily completing IDCCM, okay. But we have some like option to directly appear for Ifccm, I'll tell. So direct registration for Ifccm for post MD candidate will be accepted, but such candidate should pass IDCCM prior to appearing for Ifccm. That is mandatory. So duration of course is 2 years. So basically you can enroll for the Ifccm, but first you pass the exit exam of IDCCM, that is post MD or DNB, and 1 more year you appear for the exit exam of the Ifccm, okay. So direct entry to Ifccm means without doing the IDCCM is possible if we have FNB, DM or DNB. DNB is not yet exited currently, okay. So there is a possibility to appear for IFCCM exam directly if you are post FNB or DM or DNB critical care medicine in future. So those who have cleared FNB DM critical care medicine allowed for direct entry to IFCCM examination. Candidates who has a foreign qualification in critical care, so subject to approval from College Board, that is the Indian Society of Critical Care Medicine. So those who have a foreign qualification in critical care can directly apply for IFCCM 2 years after their return to work in India. Means they should mandatorily work in India for 2 years, whatever the degree it may be, FJICCM, FJFICCM, okay. So or it may be UK or US trained critical care medicine degree. So however, the candidate should be working in an ISCCM recognized institution, means where there should be an IDCCM or IFCCM program. So post MBBS CTCCM trainees, I told they are eligible to go through IDCCM for 2 years, but they are not eligible for IFCCM course even though they cleared the IDCCM. That's why I suggest, so if possible, don't put a full stop post MBBS. It is a competitive world, so competition is like hell, okay. So get a post graduation degree, then you narrow down your career to critical care medicine. Either it is an IDCCM, IFCCM, DNB, DM critical care medicine. So other than these things, we have some university run Pdcc programs, postdoctoral certificate courses, like we have in SGPJ Lucknow. Even in Karnataka, we have from Rajiv Gandhi University. Maharashtra, which is from Maharashtra University of Health Science, MUHS is having 1.5 year certificate program in critical care medicine, okay. So many of the institutes, even JIPMER is having, CMC Vellore is having Pdcc program. But I suggest, so this IDCCM, IFCCM is well accepted across many of the corporate centers in India, okay. So better if you have an option between IDCCM and Pdcc and you want to do only 1.5 year program, go for IDCCM, IFCCM than going for Pdcc and all. Take home, okay. This is the message you need to understand. So the structure of IFCC exit exam, so exam will be conducted by 4 examiners in ICU setting, okay. So it's a bedside and will include 3 clinical cases and a communication skill, very important in critical care medicine, okay. How you are going to declare the death, how you are going to break the bad news, how you are going to communicate in relation to organ donation and all those things, and how you are going to communicate with a so-called difficult family. So all these things are very important for IFCC exam and even FNB, DM, DNB exit exam also. One station will be on communication skills, very important, okay. So part 2, again, which is having 4 stations, logbook is very important. So you need to submit a proof of some research project, okay, or some paper which you published or presented. Without that, you are not able to get the IFCC cleared certificate. So it is mandatory, either you present one case or a study in a national international conference, or you publish a data, either it may be one original research or maybe case report, case series in an international or national journal. That is mandatory for the exit exam of IFCCM. So again, other viva including investigation, hemodynamic monitoring, ventilation, ACLS, ATLS, okay. So one critical appraisal of the paper is also currently included in IFCCM exit exam, okay. So both the parts are mandatory for total clearing up of the IFCCM exam. Passing in each part separately is mandatory with a minimum 50% for each section. So this is about IFCCM, post IDCCM 1 year, okay. There is a possibility for direct appearance to IFCCM exam, those who completed some foreign degree after they worked in India for 2 years, or those who are having DM or FNB or DNB critical care medicine, okay. What are the options outside India? So most exciting for many of the people. So in critical care medicine, what are the options outside in India? So basically we have the options in US, okay, in UK, Australia. So these are the 3 different broad categorization. We can have some options in critical care medicine. So US, I'm not going to discuss because that is USMLE, internal medicine, 3 years. After that, you have to opt for critical care medicine, another 3 years kind of this one. So that is almost 6-year program. You do whatever in India, okay. So that is 6-year program. in US. You have to clear USMLE, whether you have an MD anesthesia, MD general medicine, doesn't matter. So you have to go through this like tenure of 6 years, 3 years basic internal medicine and 3 years of critical care medicine. There is a proper super specialty there. So that is in US. Okay. We have options in UK. We have options in like Australia, which we discussed. So this is the option in like Australia. See, when it comes to Australia, so one possibility, you have your FNB, DNB, DM critical care, IDCCM, IFCCM, whatever, and you appeared through the like IELTS exam or occupational English test, and you have a like score of 7 in each and 7.5 aggregate, that is for IELTS or occupational English test OET of grade B. So then you have to apply to individual institute. So they ask for a reference and they do some sort of like digital Viva. So maybe Skype or Zoom, some interview they will take, and you need a strong reference from your institute head. It's like your head of the department or where you've done your critical care training and all. So based on that, they will give like selection output, whether you selected or not. So there you have an option to work as a fellow, as a registrar in critical care medicine, depending upon your CV, how much publications you are having, how many years of experience you are having, okay, what additional steps you have done during your training and all. Based on that, they will give a post and like all these remuneration and all those things. Okay. Again, if you want to pursue any additional degree, so there is something called so FJFICM, Fellowship of Joint Faculty of Intensive Care Medicine, Royal Australian College of Physician and Australian and New Zealand College of Anesthetist, that is called FJFICM. So you'll get the details from this website. So it is also like similar to that of the FRACP, Fellowship of Royal Australian College of Physicians in Intensive Care Medicine, FCICM, Diploma of Fellowship of College of Intensive Care Medicine of Australia and New Zealand. Duration is 6 years. Okay. So whatever you done here, whether it's a DNB, MD, so the duration is going to be 6 years and you need to clear so Australian Medical Council exam, AMC exam. So the training is going to include both anesthesia, internal medicine, so along with the critical care medicine. Assume you are strongly from anesthesia background, they will not consider your degree, but they consider your 3 year as a training period in anesthesia. If you are from MD anesthesia, DNB anesthesia, then your major training is going to be another 3 years in internal medicine, 3 years will be critical care medicine. But if you are from the internal medicine background, then your training so initially will be on anesthesia, then to critical care medicine and all. So, but AMC is required, Australian Medical Council exam, IELTS, occupational, so OET, either of these two is required. So lengthy process, but a couple of candidates like in India also have performed this like 6 year course of critical care medicine. That is one option in Australia. Okay. So again to United Kingdom, that is UK, see, to do any sort of training or like work as a specialist, so specialist registrar in United Kingdom, so you need to have a GMC registration, that is mandatory. Okay. So how to get this General Medical Council registration after completing post graduation? So one way is, okay, if you want to go to UK, so clear both parts of PLAB, so which is slowly being phased out, and like it is not currently an option, particularly for people who are from anesthesia background, because there are other like routes to get a GMC registration. PLAB is bit tough. Okay. So no need to go through the PLAB. So not worth it according to me. So current scenario. So after finishing MDR, DNB in anesthesia, because there are lots of other routes. Okay. One route for GMC registration since 2019. So if you clear European Diploma in Anesthesia and Intensive Care, that is EDIAC, so it is one eligible criteria, you can get the GMC registration. So an avenue worth trying for once who are thinking in long term. Okay. So you clear the EDIAC and you are able to eligible to get the GMC registration. You apply where is the vacancy and they will do some sort of Viva, some like discussion on Zoom or Skype. So if you have a EDIAC ready with you with a post-graduation degree with a good CV, so you can get the GMC registration and you can start working in UK as a specialist registrar. Okay, so other thing is clear FRCA primary, that is going to be MCQ and Viva OSCE based like pattern. It is more difficult exam than EDIAC, but it is the best way forward, because like if you complete FRCA, okay, so you can opt for a bit early to get the consultant post in UK and all, but it is a bit tough. Okay, first you have to enroll for an MTI post, so that is medical training initiative, eligible only for post graduation, like having a minimum of 3 years of training in anesthesia. So no exam is needed depending upon vacancy. So easiest way to get into UK currently is MTI post. Okay, so you take an MTI post, means that is again based on your like post graduation. So and along with that of what is your CV and the availability. So you appear for some like Viva interaction on a web based, and they opt, means give an option for you to work in UK, and you clear IELTS or OET exam, that is mandatory. Then that is called medical training initiative, that is for 2 years they will give tier 5 visa, so depending upon your like commitment, work commitment and all. So then you can opt for FRCA after around 2 years of working there in the UK with the GMC registration and all. Okay, so that is one method. So clear European diploma in intensive care, that is the EDIC. Since 2019, it is also recognized. If you have EDIC I, EDIC II cleared, so you can directly get the GMC registration and you can work as a specialist registrar in the UK. So after some time, you can have an option to become a consultant. I will tell so how it is going to happen. Okay, so this is the medical training initiative. Currently there are lots of MTI posts available in UK. So MTI posts are offered for maximum of 2 years, that is 24 months. So this is to work in anesthesia and or ICU, because in UK most of the ICUs, okay, so are managed by anesthesia. There is no separate ICU. You need to work in anesthesia also. See, that's why as compared to India, so that part is bit not so well established demarcation in terms of ICU, like demarcation in UK and all. Currently we have a dedicated ICUs. Okay, we will not practice anesthesia and all. It is separate super specialty branch. But in UK currently, if you want to do anything in ICU, they expect you to work in anesthesia also. So that is in the MTI post. So provide evidence of at least 3 years within the last 5 years in anesthesia or intensive care medicine training outside UK and European Union. So basically that is called IGM training. It's like, so those who are developing countries, so if you have 3-year training in anesthesia or intensive care medicine, you are eligible to work as a MTI post, that is for 2 years in UK. Provide evidence of post-graduation qualification acceptable to the college. So it should be so recognized degree from India or any of the developing countries to appear for the MTI post in UK, that is for 2 years. Okay, final FRCA. So when you enroll for MTI, slowly you can enroll yourself for FRCA after 2 years. So completed 30 months of training in anesthesia. Okay, so that is the MTI post and all. So at least 18 months must be spent in approved post in the UK or Republics of Ireland for international doctors. A minimum 12 months of overseas training in anesthesia combined with 6 months working in an approved UK post will be accepted. That is for FRCA. So basically you have to start with some MTI post. Okay, so then you can opt for FRCA after at least a 2-year, minimum 2-year period and all. So there is something called CESR training, that is called CESR training. So someone who is already having a very good CV, 5-6 years of experience post MD, post DNB in anesthesia, they are practicing critical care medicine more than 5 years. Okay, very good CV in terms of publication, presentation and all. So with that candidate is having EDIC or EDIAC. Okay, so then you can go for this CESR training directly. That is a 1-year locum consultant, consultant post they will give. So you will be called as a locum consultant. It is not a permanent consultant job. So but in the 1 year you need to do this so-called CESR training, that is a paperwork. Okay, you need to maintain the logbook and you need to show that credentialability. Okay, so credibility and all. So basically you need to show you are thorough in doing the like presentation, publication, research work, So procedures, communication and all, 1 year you need to demonstrate all those things, then you can get a permanent consultant. Otherwise, so if you are a fresher post MD, you've gone through the MTA to become consultant, it will take 6 to 8 years in UK. Very, very important. So CSR training stands for Certificate of Eligibility for Specialist Registration, and it is the route to specialist registration for doctors who have not completed a GMC approved program, like they have not done any main program in UK in anesthesia or internal medicine, okay, but who are able to demonstrate that their specialist training, qualification and experience are equivalent to the requirements for the certificate of completion of training. That is the CCT, that is the mandatory thing which is required to become a consultant in the UK. So you have not done any full-time program in UK, but you have that like credibility, you have that experience, qualification and training in that particular specialty, so that you have to demonstrate over a period of 1 year. That is called CSR training. Okay, so next is EDIC part 1. So basically this EDIC part 1 exam, okay, I told since 2019, so it is been allowed to have eligibility for the GMC registration. That's why currently everyone want to do EDIC, everyone want to do EDIC. Remember, that is after post MD or like DNB. So in general medicine or internal medicine, means like internal medicine, pulmonology, anesthesia, emergency medicine, you can appear with at least 1 year of working experience in critical care medicine. You need to like produce that experience certificate of 1 year when you appear for EDIC part 1 exam and all. So it is being conducted in 2 sessions, 6 months apart. So usually like spring session, which is going to happen in April. So, and again, one autumn session is going to happen after 6 months. So 1 year of ICU training post graduation is needed. So the exam is going to be around 3 hours. See, one question which I used to get is, sir, is EDIC is very, very superior kind of this one. Remember, so EDIC is like a cherry on your base, that is cake. So you need to have 1 degree, whether it is an IDCCM, Ifcc, okay, so DNB, FNB, DM critical care medicine, first get that degree, okay, then you get a EDIC and all. So because EDIC is not a full-time program, it is not a full-time program, so it is like add-on, it is an like some more addition to your CV, but you should have a full-time program that should be your foundation. So this exam is going to have 100 MCQs. Each question will have either 4 or 5 stems. So basically A type and K type we have. So who failed the written exam must wait for at least 1 year prior to being allowed. So that's why without proper preparation, don't appear for EDIC part 1 exam and also again you need to wait for 1 year. So type A question, 1 single best answer among 5 questions, wrong or unanswered blank like questions are equal to 0 points. There is no negative marking here. Okay, so type K, you have 4 true or false statement. Okay, so which of the following is true in relation to ARDS? So ARDS need lung protective ventilation, ARDS always need high PEEP. So all the patients with ARDS will respond to recruitment maneuver. ARDS needs bit negative fluid balance. So basically these kind of questions they are going to frame. So true or false, true or false. So 0.5 point for 3 out of 4 correct answer. If you answer all the 4 true to true, false to false, so then you will get 1 point. Okay, so no negative like mark. So answer all the questions. Wrong answer, do not subtract the total count. Very, very important. You adjust the time. So answer all the questions in EDIC part 1. But so if you answer correct answer for A type, you will get a full mark. Wrong answer, 0 mark. So K type, at least 3 options are correct. So then 0.5, all the 4, you will get a 1 mark and all. But you need to prepare properly because EDIC part 1, so they concentrate on COPD, asthma, trauma, obstetric critical care medicine, burns. Okay, so then hemodynamic monitoring, including PA catheter, CVP and all. So head injury. Okay, so along with that ischemic stroke, hemorrhagic stroke, acute fulminant liver failure. So these are the very important topics for EDIC part 1, very, very important. So don't forget to revise all these at least topics, whatever you have read for EDIC part 1, like exam appearance and all. Okay, so EDIC part 2, registration for spring session will open on Monday, that is on January 10th, 2022. So exam will be going to be conducted on May 31st, that is on Tuesday, 2022. So 3 different clinical scenarios, 3 cases. So previously it is going to happen. So in physical, okay. So EDIC II, EDIC part 1, we used to travel to one session in Dubai. Okay, that is the nearest. Other sessions are Vienna, that is Austria, Prague. Okay, so UK, Dublin, Ireland. So different like European countries, they used to conduct EDIC part 1 and part 2 also. Currently, both are like online. So you have to follow the instruction. So there are some instruction given how to prepare your room. So what gadget you need. So what is your connectivity speed, what all the things you need to have before appearing for EDIC part 1 and part 2, so that you can go through the instruction which are given in the website and all. So in the computer station, so they will give interpretation of imaging curves. Curves are very, very important. It may be thromboelastography, IABP, okay. So or it may be CVP, arterial line, PA catheter. So lots of things in and around monitoring, ICP monitoring also. So you need to like go through all these curves. Sometimes they give a small case scenario and they will give curve. So they are going to interpret this in a computer stations, okay. And biochemical scenarios, so these may be routine ABGs, hyponatremia, hypernatremia, hyperkalemia, high lactate, okay. So anion gap, DK, HHS, so these kind of scenario, refeeding syndrome. So all these things are going to be asked. See, in EDIC part 2, you need to remember, they want to check your knowledge whether you are going to be safe at the bedside or not. So may not they ask so some sort of very high-fi evidence which is currently happening and all, but they are going to ask so-called like landmark trials. So those are called as the therapy changing trial. So you should know ARMA trial, okay. So LOVE trial. So these are like high PEEP, low PEEP in ARDS and all. CESAR trial in like ECMO in ARDS and all, okay. Chest Christmas crystal, 6S trial, SAFE trial. So these kind of landmark trial they are going to ask in EDIC part 2. But again, it is around 30% of the questions are going to be common sense based. So they will not express anything. If you tell wrong also, they will tell yes, yes. If you tell right also, they will tell yes, yes. They will not comment anything. So you have to be very careful. So in answering, but like if you answer very quickly in a rationalized way, you will get more and more questions and more and more chances of passing, clearing the EDIC part 2 also. So total duration may stretch over 1.5 to 2 hours for EDIC part 2 exam. Very, very important, okay. Then we have EDIAC, that is European Diploma in Anesthesia and Intensive Care. This is after your specialty training in anesthesia, okay. So we have like 2 mandatory components, part 1 and part 2, like that of the EDIC. And there are some training modules available that is called online assessment, OLA, home-based online assessment, that is called HOLA, okay. So in training assessment, ITA, these are optional, they are not mandatory. So part 1 usually will take place so in the September month. In 2022, it's going to be on 10th September 2022. So registration will open in March 2022. So 2 MCQ papers, one covering basic science and other clinical anesthesia and intensive care. So basically, you need to have anesthesia and ICU, that is critical care medicine, thoroughly read for EDIAC exam also, okay. So criteria for entry, candidates of any nationality shall be eligible to so appear for European Diploma in Anesthesiology and Intensive Care. So the candidates will be admitted to part 1 examination provided they are medical graduates, okay. They should be at least having an MBBS graduation. So candidates will be admitted to part 2 examination, so provided so they have passed the part 1 examination and are certified anesthesiologists. So in any country, means they should clear the MD, or they are the trainees in the final year of their training in anesthesiology in one or more of the recognized like colleges, recognized like medical councils in particular country and all. So part 1 you can appear on the basis of like MBBS with some sort of initial training and all. Part 2 mandatorily you need to complete part 1. So along with that, either at least you should be in the final year of like MD or DNB of the anesthesia, or you have cleared like MDR, DNB of the anesthesia before you appear for the part 2. So this is, I told, online like assessment, in training assessment. So these are just some sort of preparatory exam for EDIAC part 1. So they use 2 sets of 60 multiple choice question, that is the part 1, with 5 true or false answer to be given for each question. The first section correspond to paper A, that include basic science, and the second paper, that is paper B, include anesthesia and that of the ICU, that is critical care medicine. Okay, so this means that each set of question has a maximum score of like 300 marks, 1 mark for correct answer, 0 mark for blank or wrong answer. Again, there is no negative marking here. Okay, so basically you have 60 MCQs, so with a 5 true or false. Okay, so this is going to be like 2 sets with the paper A and that of the paper B, which include basic science, anesthesia and the ICU. Total marks are going to be 300 marks. So part 1, this you can go through the instruction. So how to prepare, and means what exactly the structure of EDIAC part 1 and all. So part 2, again, which is Viva based. So oral examination are held annually between February and December in several countries simultaneously. Okay, so in the oral examination, so basically part 2 examiner use a marking system which is divided into 3 marks. So the mark are 0 fail, 1 borderline and 2 pass. So basically a score of at least 25 out of 40 you should get. So the examination of each candidate is held in a single day, during which there are 4 separate 25-minute oral examination. In each of these, the candidate is examined by a pair of examiners, in most cases one from host country, okay, of the examination, and the other from the outside of the host country. So basically currently EDIAC part 1, part 2 is also like online, so it is not physical. The oral examination embraces the same range of basic science and the clinical subjects as is covered by the part 1. So basically you need to understand the structure of EDIAC. So EDIAC part 2, you need to thoroughly read both anesthesia and critical care medicine for EDIAC also. Okay, so whatever you read during anesthesia final year, that is going to be like sufficient for anesthesia. So you might not require any additional things to be covered, but definitely you need a thorough reading on critical care medicine. Okay, so without that you're not able to clear the EDIAC part 1 and part 2, because which include critical care medicine aspect also. So move on to how to prepare. Finally, what to read and how to prepare. One thing you need to understand, so whenever you prepare for any sort of exit or entrance exam, okay, whether it is EDIC, EDIAC part 1, part 2, Neet super specialty, IDCCM, IFCCM exit exam, post MBBS exit exam, okay, or DM, FNB, DNB critical care exit exam, you need to dedicate yourself. So consistency, continuity is very, very important. See, critical care medicine is very volatile. You will not remember lots of stuff, lots of trials, okay, so lots of dosings, so you might not remember. For that you need a regular follow-up. Revision is very, very important. See, I will tell, so during our residency handover and all, so our handover itself is a huge discussion. It is an academic discussion. So people used to attend my taking handover and giving handover sessions and all during my residency, because I used to discuss lots of stuff during the handover to just to make sure we are revising every day kind of this one. So that is how you need to like prepare for any sort of exit or like entrance exam. Okay, so we have an answer for all these things, that is the master classes in critical care medicine. So this is with the idea to cover entire stuff of critical care medicine. Okay, so basically which we have currently near about more than 1200 delegates registered since it started in the November of last year. So 2021 means 2020 November we started. In 1 year around 1200 1300 members registered for master classes in critical care medicine. So initially we started with around 60 topics. Okay, so currently we are up to near about 100 topics in critical care medicine, which covers entire thing. So that is in the upcoming 4th batch. So each lecture spread over a period of 1 hour, 1 hour 15 minutes, followed by MCQ discussion, so interactive discussion and all. So 100% success rate if you just adhere to the master classes, and if you read one review article at least, which we post in the closed group, and you revise, and dedication is very, very important. See, if you register for the master classes in critical care medicine, but you're not able to watch the videos, take your notes, okay, not able to revise, doesn't mean. So that is apply for anything, okay? If you thoroughly follow, because that is the review which I got. So in the last 1 year, enormous reviews, okay? So very, very good high level positive feedbacks in the master classes in critical care medicine. If you just follow the class, you are able to clear EDIC part 1, part 2 EDIAC, because those candidates who not able to clear in the 3 sessions of EDIC part 1, so with a single attending the classes of master classes, they cleared EDIC part 1 and part 2 also within the 6 months, not even wasting 1 year also. That is the impact of these classes, fine-tuned to cover from the basic to the advanced through the evidence, practical aspects, theoretical aspects, tips in between, okay, what to remember, what you need to give weightage, MCQs, reading material, and we have like offline covering support also. Suppose if you have any doubt, so you can interact with me on the WhatsApp, and we have something called Voice of Critical Care Medicine Telegram group. So where we are going to have all these communication. So if you frame some question, case scenario and all, so I'll answer with a voice message, and that will get accumulated in the Voice of Critical Care Medicine. That is a Telegram group. So you can refer there itself. We have near about 3,000 to 3,500 questions answered till now. That itself is a huge library of critical care medicine. Okay, so basically we are coming up with a 4th batch of master classes in critical care medicine. So this batch we have like planned to upload 3 pre-recorded videos, okay, in a week, and 4th lecture is going to be live interactive. You can like interact with me, so like clarify your doubts, including the career, including the doubts of the previous session, like live interactive session. The whole thing will get recorded, including MCQs. So live interactive session, new lectures, everything. So 3 recorded, 1 live interactive session is going to happen at the weekend or in a specified day. So the entire month schedule we are going to give in the last week of that previous month. See, suppose so January rota of all the topics, so we'll go structurally from the sepsis, hemodynamic monitoring, like that only. The entire rota schedule you are going to get in the like month end, that is December end, for the entire month of January. So again February will get in the January end and all. So each topic winds up with 10 MCQ discussion, which are targeting the Neet super specialty. So IDCCM, IFCCM exit, so EDIC, EDIAC pattern, K-type, A-type mix. Okay, some questions are case based, some questions are straightforward answers and all. Okay, so is it just to meant all these master classes in critical care medicine only for some exit or entrance exam? Answer is no. Okay, currently those who are practicing anesthesia, internal medicine, pulmonology, emergency medicine, so we have near about 300 candidates like that who taken master classes in critical care medicine to upgrade the knowledge. Okay, so in critical care medicine, even though they are practicing since 15 years, 20 years in the field, in that particular field and all, so it is meant for those who are from the background of anesthesia, internal medicine, so emergency medicine, pulmonology, chest medicine, even super specialists like some nephrologist, it means like endocrinologists also taken this master classes in critical care medicine. Even for post MBBS candidates, post DA, DTCD, MDDN, so it has been fine tuned to include all the aspects. Okay, that is master classes in critical care medicine, wind up over a period of 5 months. Okay, to cover near to 100 topics. Okay, so we are going to have all these recorded lectures till total 6 months of the course. So course is going to start in first week of January, which is going to wind up somewhere in the May end. So that is a course duration, but the videos are going to remain till June end. So first week 3 lectures, another 3 lectures in the next week, another 3 lectures. So in a month you will have at least 12 to 14 lectures accumulated in the video library. Next month another 12, it become 24. So like that you are going to have total lectures over a period of 5 to 6 months, which are going to accumulate till the end of June. Okay, so you can watch on your laptop, desktop, mobile multiple times. Okay, you can take your notes. Okay, so you can clarify the doubts even not only online, during live interactive session. Even if you're not able to attend the live interactive session, you can put the personal message on the WhatsApp. I'm going to answer as a voice message. If you need any additional, like some sort of reading material, articles, so what to prepare, how to prepare, so all those career options also going to be guided personally by me on one-to-one basis. Okay, that is the beauty of master classes in critical care medicine. I think in critical care medicine in the last 1 year, it is the one which have an high impact globally. Okay, so this is, I'm telling with the confidence. So because that is the feedback which I got, even not even a single negative feedback which our team received on the master classes in critical care medicine. Those who thoroughly followed, okay, dedicatedly watched, 100% success rate. So initially when I started, I was having some hesitancy. So what is going to be the impact and all. Even on a first lecture on sepsis, septic shock in the first batch itself, I got a very good, huge positive feedback. So this is what the people enjoyed, what the doctors, those who want to learn, upgrade, and appear for any exit or entrance exam in critical care medicine, they want. So standalone faculty, I am the only one-man army for the entire course of master classes in critical care medicine. Okay, so that continuity will be there because I know what I told in the class. So then it is easy for you guys to follow, okay, communicate, and have some sort of reinforcement repeatedly to consolidate your memory for any sort of exam or any sort of clinical practice, and it become a huge hit even in outside India also. I will give example. See, people, those who are practicing like ICU in Qatar, Oman, Bangladesh, Pakistan, Nepal, Cairo, Egypt, UK. So they put up feedback. So with the classes, it not only helped in upgrading the theoretical knowledge, so the many of the patients' life has been survived during this pandemic, post-COVID sequelae. Okay, so they put lots of case scenarios. Sir, this is the challenging case. This is a pregnant lady with COVID. Okay, how to manage? So this is what we stuck with, high CO2. This is the MDR organism, XDR organism. So this is the hemodynamics, what to do. This is the lactate. This is the ammonia. So lots of patients had a life following just master classes in critical care medicine. This I am telling with a confidence. Okay, so these are the topics which we included. So it follows the same sequence from the January 1st. Okay, we are going to follow the same sequence. First, we'll start with infection, anti-infectives, sepsis, empirical antibiotic, community-acquired pneumonia, fungal infection, newer antibiotics. Okay, MDR organisms, carbapenems, so tropical infection. Next, hemodynamic monitoring, which include basics, advanced hemodynamic monitoring, cardiac critical care, including heart failure, pulmonary embolism. Okay, so acute coronary syndrome, atrial fibrillation, perioperative sepsis, cardiomyopathy. So newer heart failure medications, ARDS. So it is being included as a part and parcel of respiratory critical care also. So we have ventilator associated pneumonia, COPD, asthma. Okay, landmark trials in ARDS. Okay, so ARDS ventilator strategy. So case-based approach in ARDS, mechanical ventilation, basic, advanced, so ventilator graphics, weaning difficulty, troubleshoot of difficulty in weaning, fluid, electrolyte, blood, massive transfusion. Okay, damage control resuscitation, IV fluid therapy, crystalloid, colloid, among the colloids, among the crystalloids. So with the evidence backup and all. Okay, in which disease specific fluid options, in which condition what to use, hyponatremia, hyperkalemia. Okay, so hypernatremia, endocrine nutrition, a general approach to nutrition in critical care, that is very important currently. Okay, disease specific nutrition, so what is called immunonutrition, pharmaconutrition, refeeding syndrome, clostridial difficile, DK, HHS, hypoglycemic acute emergencies and all. So gut, liver, pancreas. So we have acute fulminant liver failure, abdominal compartment syndrome. Okay, severe acute pancreatitis and its complication, neurocritical care from subarachnoid bleed, ischemic hemorrhagic stroke. Okay, GB syndrome, myasthenia gravis. So like neuroinfection including meningitis, encephalitis. Okay, status epilepticus, that's also very, very important. ICU acquired weakness, including critical illness, polyneuropathy, polymyopathy and all. So oncocritical care, again, febrile neutropenia, tumor lysis syndrome, leukocytosis syndrome. So post-transplant patient care in ICU and evidence-based, whether it's a solid organ malignancy or it is a hematopoietic stem cell transplantation. So trauma, burns, snake bite, abdominal trauma, traumatic brain injury. Again, so like ATLS, a general view, we have around 10 to 12 miscellaneous topics, including toxicology, a general approach. So ECMO basics, okay. So newer anticoagulant, so and DVT treatment and all. So ACLS, post cardiac arrest care. So bundle care approach in ICU, what are its limitations, what are the criticism around it. So end of life care principle, brain death diagnosis and organ preservation imaging in ICU. So these are the topics, near about like 70 to 80 topics already covered. So there are some topics, so in a single day we are having three topics there. Okay, so if you see like this topic, disease specific pharmaconutrition refeeding syndrome, 3 topics in a single day. So diabetic emergencies, DK, HHS, hypoglycemia. Okay, so if you like split all these things, you have already 80-85 topics which are already pre-recorded, which we put like 3 videos in a week. With 1 video that is a newer topic, I will come online with an interactive session at the end of the session and all, okay, which again get recorded, which again uploaded into your video library. So these are the additional topics which we included in the upcoming 4th batch. So ICU management of upper and lower GI bleed, treating HIV patient, that is what is ICU as an intensivist we need to understand. So evidence-based management of COVID-19, what happened till now. So because in the previous classes I have not included on COVID, because it is an evolving, okay, we don't know what we are doing. So what is the recommendation? So I tried to put this topic in the coming so new batch, that is a 4th batch. So systematic approach to airway management in ICU, because many of the people they are attending from the pulmonology background, emergency medicine or internal medicine, they need, okay, so like airway management in ICU, how it is different. So rapid diagnostics and therapeutic drug monitoring, okay, we have currently lots of multiplex PCR, pan PCR based approach. So what it is, so ICU organization and structure, what we need to understand, okay, role of extracorporeal filters. So filtering the sepsis with a different extracorporeal circuits like cytosorb, oxalis, toremixin, LPS adsorber and all. We have a major landmark trial on toremixin and all, which we are going to cover. So critically ill patients, like managing critically ill post-surgical patients. So with a sepsis, a practical based approach, it is the surgical skin site infection. So that is also a bit challenging. Post-operative MI, pulmonary embolism. So what practical consideration? So confusion regarding thrombolysis, other like therapeutic intervention, infection control policies, how to take care of the drains, lines, okay, isolation principle, biomedical waste management. So nothing is left. Along with that, I'm going to include other couple of newer topics, okay, so which are like patient self-inflicted lung injury. So this is some new concept which evolved with this COVID-19, diaphragm protective ventilation. So to understand that concept with some clinical example and all. So lung stress and strain in mechanical ventilation, microcirculatory assessment in ICU. So where we are today, what is the evidence supporting that PCO2 gap, its practical utility at the bedside. So lactate in and around, okay, de-resuscitation concept, some are already like spoken in some of the conferences, but I am trying to cover all those things. So immunomodulation in ICU, there are lots of things, including steroids, ulnostatin, methylene blue, Sepsivac, thymosin alpha, interferon alpha, Marix protocol, that is steroid, vitamin C, thymine therapy, that is called Marix protocol. So this covers entire critical care medicine and nothing left in critical care medicine in the master classes, which is upcoming 4th batch. Okay, so basically registration is already ongoing. I strongly suggest whatever you want to achieve, whether it is an EDIC, EDIAC, IDCCM, IFCCM, DNB, FNB, DM, post MBBS, or you just want to upgrade your knowledge. So this is the one platform with a confidence I can tell. So this is the best platform currently available. So only one answer, masterclasses in critical care medicine. So visit this website www.harishcriticalcareclasses.com. Okay, so this is my personal number, personal mail ID. If you have any queries, you can put across this also. We'll take some questions now. Dr. Irfan, so what are the options available after FNB critical care medicine for a better future? I mean, both in India and abroad. Is any further training required? See, if you've done an FNB critical care medicine, that is definitely considered as 2-year structured training in critical care medicine. If you want to go to UK, you can opt a post through the MTI. Okay. If you have EDIC, you will get a direct GMC registration. So, or else you can like pass through like Viva based on like some sort of digital platform. You will get a job in the ICU itself. Okay, because you are trained structurally, but you might not get recognized that as your degree in critical care medicine, but you are able to get the job in UK. You can go to Australia also. Even couple of my students whom I given a reference letter, they are working in Australia and UK on the basis of FNB and all. So when you go there, you can plan to clear the EDIC, or you can so keep the track on clearing EDIC year only, EDIC part 1, part 2. So after going there, after you started working as a specialist, then you can opt for maybe some sort of like CSR training, and you can opt for later consultant post and all. So there is an option. So other than that, you can go to Middle East like UAE and all, better salary, no tax and all. But basically your FNB is not recognized there. You will get a specialist work permit to anesthesia, but you are allowed to work in ICU, but your means license is going to be in the anesthesia. But if you are a DNB or DM critical care medicine, okay, so then you will get a like critical care license in it means UAE countries and all, maybe Abu Dhabi, Sharjah or Dubai. So but if you want to become a consultant in any of these countries, you need a post DM or post DNB at least 5 years. So then only you are able to get the consultant post in UAE and all. So these are options in abroad. In India, you will definitely get like at least an associate consultant, junior consultant immediately after FNB. But currently there is no FNB, it is been collapsed, so cancelled, and it is become currently DNB in critical care medicine. So DM was already there, but the limited seats. Dr. Irfan again, is it mandatory to have a membership for appearing in EDIC? Total cost, any idea, sir? See, it cost about around 600 to 500 to 600 euros. If you have a ESICM membership, you have an advantage. So some at least 70 euros you'll get a discount, and you will get a continuous emails from the ESICM, European Society of Intensive Care Medicine, regarding some like live programs, okay, some interactive sessions and all. Some journals you are able to access directly, that is intensive care medicine journal, where you will get a good evidence-based stuff and all. So I suggest get a ESICM registration before you appear for EDIC part 1, part 2 and all. Yes, if one fails, okay, you need to pay again the fees for EDIC part 1 and part 2. So there is no exemption for that. Okay. Dr. Pawan, sir, what are the options after Pdcc exit? See, Pdcc, definitely you're at par with Idccm and all. So, but the acceptance among the corporate, because many of the corporate hospitals, private hospitals, they are aware of this Idccm, so more than that of the Pdcc. But if you get a Pdcc from any particular university and all, you are able to like practice critical care medicine with the option of junior consultant or maybe associate consultant. You clear the EDIC, I strongly suggest, because that will add to your CV and all. Then you can grow with your hierarchy, with your like timeline, with your experience and all. So, but this is the comparison between Pdcc and Idccm. There is an option, no worry on that. Dr. Abdul, thank you. I'm a resident in critical care medicine in Bangladesh, did MRCM part 1. So after completion of my MD, can I go for EDIC part 1? Yes, you need 1 year training certificate in like intensive care medicine. So you need to submit with your MD degree when you apply for EDIC part 1 exam. You can appear, no doubt on that. So there is one more question. Does the critical care career involve bedside patient care and night duties, even on reaching HOD post, unlike medicine, There are no units, no. So definitely once you become a consultant, even in some institute, it is basically institutional practice. But many of the institutes, if you are up to the associate consultant or a consultant, you are exempted from night duties and all. But some institute, you have to do night duties in associate consultant level also. But if you become consultant, 90% of the institute, no need to do the night duties and all. HOD, obviously, nowhere I heard they will do night duties and all. Okay, so even in my career, after my MBBS, MD, DNB, DM, EDIC, MBA, my first job is head of the department. First job in my career is head of the department of critical care medicine. I have not done any night duties till now. Being a critical care medicine specialist, when I took as a proper career and all, no worry on that. Okay. Is there more of burnout? No. Okay. So I told, if you thoroughly read during your residency, you thoroughly understood the evidence. So how to apply what you learned, how to speak to the relatives, how to counsel. So you will not feel burned out. See, when you have a limitation of all these things, okay, you will have a frustration. If your approach is rationalized, you have a bedside teaching, bedside approach, protocols and all, you will not feel burnout. When a patient have a good life after a month, after couple of days of ICU stay, ventilator and all, you feel better. Okay, so you feel rewarded. It is not a burnt out. So during residency, you will feel stressed out, and after a certain time, you will learn how to troubleshoot what may be the problem and all. You will learn. Okay, maybe 10 out of 100 patients are a bit challenging. Okay, you need to put extra effort, extra thinking and all, but most of the cases are you will learn over a period of time and all. So how to deal with aggressive relatives? So blame the intensivist for the patient bad outcome. I told, keep them well informed. Okay, sometimes see, currently the relatives, they see your credentials. Okay, so I never faced any problem in any of the tough patients and all, because I'll put my degrees, credentials, my knowledge in front of them. So if you put that's why I'm telling, so gain as much as possible. Okay, so credentials, like credibility and all those things, then nobody is going to argue with you. Suppose if you are very good qualified with a good experience and rationalize it and all, you keep them informed, so they will calm down with that. Okay, you give the open options, don't hide anything. So you give them, means if the patient is bad, tell them all the options. Okay, continue here only, take the patient to outside hospital, take them home. So you be open to them, they are not going to be aggressive. Is open ICU preferred or closed ICU, especially in Indian? See, we can't tell any of the ICU totally closed in Indian scenario. So we can tell either a semi-closed or semi-open, because see, I can't do upper J endoscopy. I need a gastroenterologist. I can't do neurointervention. I need a intervention neurologist. I can't do couple of intervention radiology procedures. So we can do pleural tapping, ascitic tapping and all. So we need a support, and they also need our support. So it is a semi-closed than calling it as a totally closed or totally ICU. You can't run totally closed ICU also. You can't run. You need intervention. See, bronchial, some sort of clipping. So stenting, you need an intervention pulmonologist for that. Okay, if you take an help from others, so it is a semi-open, semi-closed ICU. So that debate is gone. So it is a mutual thing. They also need our support. Someone, they need to take care of their bad patient in the odd hours. So it is a mutual thing. Dr. Abdul, after MRCM completion, can I get chance to IFCCM in India? If your MRCM is recognized, okay, so you have to check with the MCI, that is Medical Council of India. So if it is recognized from Indian Council, so then you can get IFCCM in India. Dr. Yasir Sultan, please advise how to start for EDIC Part 2. So basically, I strongly suggest just enroll for the master classes in critical care medicine, because see, that covers not only the theoretical stuff, most of our lectures are case-based scenarios. Okay, so case-based scenarios, that is very important for your EDIC Part 2. Maybe hemodynamic monitoring, sepsis, ARDS. Okay, so many topical infection, many means topics are case-based approach. So along with that, at many interval, we'll discuss many of the biochemistry, hemodynamic monitoring, curves, graphs and all. That is the best way. Next, you follow like what you read for EDIC part 1, you revise that. Okay, that is very important. And any of the basic textbook which gives all this biochemistry and all. So there are a couple of textbooks available in the market. You can follow those things. But revision is very important. So they see your fluency and confidence while communicating in EDIC part 2 exam and all. That is very, very important. That comes with your knowledge. So any other questions? See, currently registration is open for master classes in critical care medicine. So the one time is around 18,000 plus GST with some sort of like additional facilitation charges will be there. So like I suggest those who want anything in critical care medicine strongly to register and utilize these classes and all. But once you register, so you need to utilize. Dr. Anil Kumar, is there any fellowship in critical care available under you or anything else for foreign physicians? As I am from Bangladesh, see, from those who done critical care, because a couple of candidates asked previously also, those who are currently attending my master classes in critical care medicine. See, we have observerships and all. Okay, you can come over here, but that is a self-funding. You will not get any stipend and all. You can do observership under me. At the end of the day, you will get, okay, so and so done an observership. So under me for this much of duration, like that you will get a certificate. So basically that is to upgrade your knowledge. So you can follow the bedside rounds. You can involve in the patient care discussion and all. Okay, you can observe the procedure and you can do the procedures also during the observership. That is one option currently available. But any recognized fellowships you can't get from the Bangladesh background in India. So that is currently the options you have. Many people, they are interested, they are given some communication to them also. So for these kind of observerships and all. Dr. Priyanka Chavan, so what is the future of FNB once DNB critical care pass out comes to work without EDIC, sir? So don't bother about all these things. Okay, so basically it is the supply demand, okay, where you want to work. Suppose if you have like 2 DNBs and 1 FNB kind of this one, so they might give preference to DNB and all. So but if only FNB is a competitor, if you have a FNB with EDIC, so you will get a preference. If no EDIC and all, you will get a preference. Then other things will add is your years of experience and all. See, till now, people without any additional qualification, they are doing critical care medicine practice and all. So you have definitely a well structured program and all. Maybe down the line, so all this comparison, competition will start. But if you want to settle in such a institute, okay, maybe in a district place, nobody is going to be with IDCCM itself. Then you are superior there. So that's why even a small 100-bedded hospital where they have 15-bedded ICU and all. So you might head the department there. Okay, 15-bedded ICU, that is a handsome number kind of this one. So we can't have this kind of weightage and all. It depends upon the supply demand. So lots of factors will come into picture when you have this kind of comparison and all. So any other questions? So if no more questions, we'll wind up here. So thank you all who attended this orientation session on overview on the critical care medicine, including the career options, including academic options, so including knowledge upgradation plan in this very upcoming super specialty branch, that is critical care medicine. So strongly suggest to enroll for the master classes in critical care medicine. That is the 4th batch, which is going to start in January 1st week, which spread over a period of 6 months. 100% you will enjoy, 100% you will clear. So what you want to achieve kind of this one. Dr. Irfan, dear sir, any options in Qatar? See, definitely, again, see, whatever you done as a degree in India, in Qatar, they will not recognize. They recognize you as a got training in critical care medicine. So, but Doha, Qatar is an option. You can plan that. Okay, even couple of my seniors, they are working in Qatar, good salary, no tax and all currently. So you will have an option if you have at least maybe a DNB, DM, FNB, IDCCM with EDIC additionally if you have, so you will definitely have a options in Qatar also, no doubt. Even woman. Okay, so all these options are there. Any other questions? So any doubts, you can directly contact me. This is my WhatsApp number also. This is my personal mail ID. And even in the brochure, we have backend team number also, Mr. Anil, our backend team. So you will also help if you have any doubt in the registration or any course related queries, you can directly contact me also. So thank you all. Stay safe. Good night. Anil, you can stop recording.